Great. Welcome back after lunch. This afternoon, we have a keynote lecture, which is going to be delivered by Scharukh, Jalisi. He's a robotic and head and neck surgeon from Boston, and he's a key teacher and trainer in the Harvard Medical School. And he has got an excellent experience in transoral robotic surgery and also head and neck cancer. Scharukh, it's over to you. Thank you.
Thank you, Jai, for Dr. Manick and Dr. Majumdar for inviting. Really excited to be here. I had looked at your agenda today, and it's a very terrific agenda for all those attendees, and really congratulations on setting this up. Obviously, we're in a different world now, COVID pandemic. Hope this goes away soon, and all of us and our families get through this in a safe manner. But I think with the vaccines coming out, I think, and people getting more and more, I think we'll be fine. Obviously, my discussion today is robotic surgery as a tool for de-intensification of oropharyngeal cancer treatment, as my title. We're going to go through this. I think there's a lot of things, a lot of newer data that keeps on coming out around this technology and the techniques and stuff. So I really have no disclosure in this talk. I think the most important thing for everyone online today is that it is not the strong, as Charles Darwin said, it's not the strongest species that survives, nor the most intelligent, but the one that is most responsive to change. So I think continuous adaptability is critical for all of us, whether we are surgeons, non-surgeons who manage diseases, that we got to understand what the new things are coming, the new frontiers, and to adapt them. De-intensify is a terminology which is to reduce the intensity of strength or something. In our world, I think as we've seen over time historically, we have gone from maximally invasive surgery to more and more minimally invasive. I think the big turning points came when we went from laparotomies for abdominal surgery to now laparoscopy, and so on and so forth. And I think that the pendulum has continued in otolaryngology, where we went from open sinus surgery now being the standard, being endoscopic sinus surgery, and beyond. And then some amazing things that we as a community of surgeons have achieved in terms of swallowing and dysphagia, what Dr. Majumdar does, some amazing stuff out there, which is all endoscopic and minimally invasive. So this is just an incidence from the United States for pharynx and oral cavity cancer. And you can see about 50,000 new cases of this disease in the United States. There's about 10,000 deaths and about 10,000 new oropharyngeal cancers. Dr. Manick, if my voice is echoing or doesn't sound good, please let me know. We can adjust the audiovisual over here. Oral oncogenic potential of HPV infection, because that's a new thing now, between the ages of 14 and 69 has been recognized. And 95% of these cancers are squamous cell, as we know. About 80 million Americans get infected with human papilloma virus, and it has now been shown to be a distinct causative agent for oropharyngeal cancer. There has been an increase in HPV prevalence in this country from about 16% in the mid 80s to about 72% more recently. Again, as you know, this epidemiological data lags behind by many years, so we go with what's most readily available. And then it has been associated with genital warts in HPV 6 and 11, but more so now in cancers such as HPV 16 and 18 for head and neck cancers, and 31 and 45 for other GYN and colorectal cancers. The profile of the HPV patient has changed as well, because we're seeing younger and younger patients as compared to HPV negative. I think HPV is an important causative factor for head and neck cancer now, at least oropharyngeal. Incidence is higher in men compared to women. People are less likely to smoke. So although the smoking and the tobacco pandemic is going down, but this HPV is taking off. And I think it's pretty endemic in most parts of the Western world. Higher socioeconomic status compared to the HPV negative counterparts, and a high lifetime number of vaginal and oral sex partners. So this all points to why I'm bringing this up, is it's important to take a good social history on your patients just to understand where they're coming from. Some of these questions are uncomfortable. How do I ask my patient how many partners they have? But I think it will help you guide long-term therapy and hopefully surveillance on these on such patients. Having said that, the oral oncogenic potential, that means if you have HPV, the chance of actually getting HPV-related cancer is not that high. It's about 6.6% in men and about 1.5% in women, and the gender difference is statistically significant. Histology is usually poorly differentiated, non-keratinizing with basaloid features, and then partners of patients with HPV do not seem to have elevated oral HPV infection as compared to general. And that's an area of active research. It's a research interest of mine, and I would encourage if there are trainees or even surgeons out there, that this is a very interesting topic to think about, that why does not the partner or spouse of a patient have cancer simultaneously? I've yet to find one where both folks in a couple have oral cancer. A lot of this was brought into our existence by Dr. Carol Fakhri and our group, who had published this article about prognosis of HPV-associated cancer. And why I'm talking about this is going to become evident as we go through these next few slides. But basically, this particular study back in 2008 was looking at induction chemo in both HPV positive and negative patients. Median follow-up was about 40 months. And basically what we saw was that HPV positive tumors demonstrated a higher survival as compared to HPV negative tumors. So that means there was a positive prognosis if you had HPV versus not. 95% survival at 2 years versus 62%. And at the same time, oropharyngeal cancers of those which were HPV positive had a better response to chemo and primary chemo radiation than those with HPV negative tumors. The important thing to remember here is this was a primarily non-surgical trial, and it depends on what lessons you take from this. For most of us, it demonstrated that HPV positive tumors have a better prognosis. That's it. Then Dr. Ang et al. Published this another article in New England Journal of Medicine in 2010. So this is just giving you historical background about this. And they diagnosed that HPV-16 was an independent risk factor. And then they were looking at data extracted from the RTOG-0129 trial, which again was a non-surgical trial which compared accelerated fraction versus standard fraction radiation. And in that, they found that people who had HPV positive had a better 3-year survival versus those who were HPV negative, 80% versus about 60%. There was death within 30 days, which was about 3.3% versus 2%. There was a lot of toxicity in both arms in this group. The key thing was there was no comparison to surgery. And that's the important thing as we go through historically and as we discuss about why what we're talking about, de-intensification becomes important in HPV positive. These are just the figures that are from Dr. Ang's article. And bottom line is, if you're HPV negative disease, based on your HPV status, you have a worse overall survival than HPV positive. Now, HPV positive patients may have a survival as high as 80%, while HPV negative patients about 30 to 40%. And that was pretty much replicated in overall survival, progression-free survival. Then you looked at P16 expression, because in most, at least clinical department in the United States, I don't know how you guys do it in the UK, we look at P16 as a surrogate marker because it's readily available in our pathology labs versus doing an HPV derived test, which may be a send out test and may take longer and also cost more money. So we figured out that P16 is a good surrogate marker for HPV, and most of the institutions will use that. We did put out a study a few years ago looking at imaging characteristics of metastatic nodes and outcome by HPV status. And we had looked at about 88 patients. Nodal metastases were more common in HPV positive patients, which was statistically significant as compared to HPV negative. In addition, the HPV positive patients showed a higher prevalence of extracapsular spread. Again, statistically significant compared to HPV negative patients. But the recurrence was more common in HPV negative patients despite all this, and was independent of the presence of extracapsular spread in nodal metastases. So all in all, when we looked at this data of ours, we said, you know, you could be HPV positive, you could have some extra nodal extension, yet your survival is going to be better just by the fact that you have HPV positive. So basically what we are looking at this point in time, and there's many other articles out there and publications that says that HPV does have more N positive disease. You'll see more nodal metastases on your imaging studies, your PET scan, and so on and so forth. There may be a higher prevalence of extracapsular spread, but there's still a less chance of recurrence. So then we went on to look at the staging system. As you can see, the staging system has now changed on the American Joint Committee, Cancer Committee staging. There's a 7th edition, and then there's an 8th edition that came out of this. And basically, up until the 7th edition, we were saying that as soon as you became N positive, if you had a lymph node, you would automatically be a stage 3 and 4 disease. And most of these patients were automatically put into an arm of combined mortality treatment, usually chemoradiation followed by surgical salvage. Which had become a norm in our country. And then early stage disease, T1s and T2s, or stage 1 and stage 2 without N positive disease could be treated with single modality treatment. Obviously, the 8th edition changed all this, and because now we had a recognition of HPV positive disease, so there's a separate category now of P16 positive oropharyngeal cancer. And in this, basically, the T stage didn't really change much because it was based on size, but the N stage changed. So there's a clinical category, which you're seeing on the left side of the screen, and then you have a pathological category, which is on the right side of the screen. Obviously, pathological criteria is met after surgery. And so this demonstrated the recognition that surgical intervention could also give you more diagnostic data to help appropriately stage patients. But as you can see, if you had N1 disease, it was 1 or more ipsilateral nodes less than 6 centimeters. N2 was contralateral or bilateral nodes, and N3, which was a new, was always there, but lymph node greater than 6 centimeters. But when you went into the pathological staging, basically we started looking at the number of lymph nodes that are available. So N1 disease would be anything that less than or equal to 4 nodes, and N2 disease pathologically would be greater than 4 nodes, and a pathological N3 does not exist. So it all depends on your nodal yield. And again, there's a lot of articles out now, which we will not belabor over here. It is what is considered a therapeutic or a good quality neck dissection, where typically in our center, we say if you have to have at least 18 lymph nodes in a previously unoperated neck to be considered a high quality neck dissection, rather than super selective neck dissection where you may get a yield of 1 or 2 lymph nodes. Obviously, post-radiated patients, all bets are off because a lot of your lymphatic package is turned into scar tissue. And so it is understandable that your nodal yield will be less. And the clinical staging changed based on all this thing that's coming out with the data, where we now have up to a T3 N2 disease considered a stage 2. And then when you become N3 and you start going into T4s, that's when you start going into stage 3. And stage 4 is now considered anything with metastatic disease based on your imaging workup or other whatever modality you use to look for metastases. So this changed that now we had T3 up to a T3 N2 disease still being considered stage 2, because we've recognized over the last decade that oropharyngeal cancer, HPV related, has a better outcome. Same thing with the overall pathologic staging. In this, you can be a T4N1 and still be considered a stage 2 disease as compared to clinical staging. This is right here. And the next one is path. So this is obviously pathological staging is after the surgery. So again, shows that if you have a post-surgical pathological staging, you might still be able to improve or help with the staging system and see if the patient's appropriately staged or not. So really the question becomes, it's HPV positive with a favorable survival. Why are we still treating with aggressive treatments? When I was training, pretty much all of our oropharyngeal cancers did automatically get chemoradiation. And we saw all the toxicities and all that because everything used to get admitted to the head and neck unit. And we would deal with these patients, and a lot of them with no ability to swallow long term. There are indications for adjuvant therapy. I put in specifically adjuvant over here. This means post surgical, but it's extracapsular nodal spread, positive margins. If you have pathological T3 or T4 disease, which means really from the oropharynx, you're going into your pterygoid muscles or extending into your bone and stuff, N2 or N3 disease. Obviously, pathological N2 is Mets in greater than 4 nodes. Nodal disease in level 4 or 5. So now we're looking at nodes coming into the lower part of the neck. Perinodal invasion is a soft call, at least in our center. So I don't know, it's all very center driven, how you folks work with your medical oncology and radiation oncology colleagues. These are the NCCN guidelines, and I just want to highlight this, that basically it has shown that if you have a P16 positive disease that's T1, T2, and no nodes, if you go through the schema of going through the surgical arm and there are no adverse features, which we just talked about, these people can be observed. And you're like, okay, it's an N negative disease. Okay, I get it. We take it out, we get negative margins, and we have a good outcome. We can save them radiation. But then the schema actually got updated this year, where even if you have N1 disease, which is a clinical N1, which is a single node less than 3 centimeters, and you go through the schema, and again, there are no adverse features, you can still watch them. So you can save them a whole modality of treatment. And the next schema is for if you have, again, a T2 N1, 2 or more ipsilateral nodes, or you can do a N2 disease or T3 N2 disease. You can again go down the surgical arm. They obviously have the choice at this point in time because they have multiple nodes to go through concurrent chemoradiation therapy, or you can go into clinical trials if you want to send them, or you can go into the surgical arm, which is if it's a unilateral disease, lymph nodes, and you go in, resect the primary, you do the neck dissections. If it's bilateral neck nodes, you can do bilateral neck nodes. And if there's again no adverse features as far as bilateral neck nodes, you can again follow them up. You can see if you can save them the whole aspect of radiation or chemo. Again, this is a joint decision in our head and neck tumor boards with pathology review, med onc review, and radiation oncology review. This is not a decision we take in isolation as surgeons or anything like that. So a lot of things have to happen. But the reason I show this to you is that the NCCN, or the National Comprehensive Cancer Network, which is a conglomeration of nearly 25 major cancer centers in the United States, put out these guidelines that have their a footprint in evidence-based medicine, and they have come up with, because of HPV positive disease, we can now, even with traditional surgery that we used to do and said, oh, you're going to go for chemoradiation, there is this whole arm of observation or not having to do adjuvant therapy. Similarly, if you go to really advanced disease now, HPV positive, you got N3 disease, or you have a T4 N3, here again, you can do concurrent chemoradiation. And again, with these advanced surgeries, and there's no adverse features, you can be fine. Again, reminding you guys about the adverse features: extranodal extension, any positive margins, pathologic T3 or T4, a pathologic, which is different than clinical, because you might see something, but once the pathology comes back, it may be smaller than what you were seeing. Multiple nodes, that's more than 4 basically, and then you go from there, and you can still be in an observation arm. Now, a lot of people say, well, you know, what if someone doesn't want to be in the observation arm and they need chemoradiation? What is the advantage of this? So early stage disease, you can equally treat patients with radiation or surgery. We know that there's plenty of articles out there. And stage 1 and 2 disease can be dealt with single modality treatment. I think the ability with surgery, you can again save radiation. This particular study came out of Europe in the GETIC study, which is a pretty famous study. It's now over a decade old. But you're able to save radiation in 72% of the patients. This is obviously the time before we had robotic surgery becoming so popular, but about the 3/4 of people could be saved given additional information from a surgery and neck dissection. This is a study which shows radiation is excellent with great local regional control, 5-year control rate of 85%, local regional control of over 80%, and disease-free survival of over 85%. So again, it's a great modality. You treat people to 66 gray, and people do fine. And then transoral resections were becoming popular in the early 2000s, where 5-year local control rate was of over 90%. So again, similar, but you can see there are trachs that had to go in, there are permanent G-tubes. Even with this, at least in the United States, we do go to a rate of permanent G-tube in non-surgically treated patients of about 3% or so. So I think it becomes helpful for those patients. Advanced stage disease, obviously, you do concurrent chemoradiation, salvage for residual disease, or you can do surgery up front, with primary of the neck and post-op radiation. And then you can do induction chemo followed by chemoradiation, which is still a category 3 because we don't have good randomized control trials comparing induction chemo. Although there have been several studies, both from the US and from Europe now showing that induction chemo does not improve survival on the patients. So typically we reserve induction chemo for people with massive tumors where we want to get some kind of a reduction in the size of the tumor to reassess and decide whether they're going to go into a surgery first arm or a chemoradiation arm, and then decide, go from there. There's another study which came from France, which was looking at radiation alone versus concomitant chemoradiation. And one arm had a radiation to 70 gray and 35 fraction, and the second arm had carboplatinum followed by radiation. And pretty much all this showed that if you had chemoradiation, you had a better overall survival, disease-free survival, and local regional control, but this was not a comparison to surgery. So really for advanced stage disease, we really don't have any randomized control trials. I think there's a lot of activity happening both in Europe and in the United States to come up with some kind of randomized trials to answer this question. This is a study looking at surgery and radiation versus chemoradiation, and basically showed that your overall survival was better in the surgery followed by radiation arm of about 70% versus 40%. And which was statistically significant, but not reaching statistical significance on local regional control or disease-specific survival. But hopefully they had a better outcome. Now here's the bottom line: that if you operate on people first, why may it make a difference in the adjuvant therapy they may receive? So according to the NCCN, if you are giving definitive radiation therapy to a tonsil or a neck or any other site, you're really radiating these sites to 66 to 70 gray to the primary site and where the main lymph nodes are. And you can reduce the dose to 44 to 50 gray to lower intermediate risk sites. For example, for tonsil cancer, level 4 and 5 would be considered low risk, so you can do that. On the other hand, on post-operative radiation, you would go as high as 60 to 66 gray. So again, you're reducing the dose from 66 to 70 to a high-risk area of positive margins. If you don't have positive margins, our radiation oncologists are willing to even reduce this down to about 50 to 60 gray, which I think became more evident with the ECOG 3311 trial, which we'll talk about in just a few slides. And then you're going to go to 44 to 60 gray in low to intermediate sites of subclinical spread. And so the bottom line is surgery can help de-intensify treatment in oropharyngeal cancer. Can you guys hear me okay, Dr. Manick?
Yeah. Absolutely.
Okay. All righty. So why does this all matter? Because of radiation effects, and dysphagia can happen as a long-term effect. And obviously, I'm not an expert on it, but there's plenty of people on this call that are experts on this. But we see the endpoint in our head and neck clinics is what is the effects of radiation. And patients treated with the radiation therapy, 78% with stage 3 and 4. About a quarter of them can end up with moderate to severe dysphagia. And this is a study that was done that's a very beautiful study showing the steep dose effect relationship of dysphagia. And basically it says that you can have a worsening of dysphagia by about 20% for every 10 gray of radiation therapy. So someone who gets radiated primarily to the constrictors, particularly the superior and middle constrictors, which is the main area where the dysphagia kicks in. And for those who have operated on patients, you can see the constrictors are very wispy kind of muscle. It turns into scar tissue pretty quickly. There's a difference between someone who gets 70 gray of radiation versus someone who might get 50 gray. And so if you can go in with surgery and help reduce that radiation effect, I think that would be great. There are late swallowing effects. These are people that are followed out for more than 2 to 3 years, looking at the swallowing dysfunction after radiotherapy was completed. And again, you can see that about 83% of people had some form of dysphagia. My biggest question to my patients when they come to clinic, whether they've had surgery or chemoradiation or a combination of, is, are you comfortable eating in public? And I think that common question will answer a lot of questions, because then the patient may say, you know what, doc, when I go out, I just don't want to have food out there because I have to swallow multiple times to get that food down. And it's a big problem from a social perspective, or people having reduced sensitivity. They may have residue in your throat. They got to clear the throat a lot. And imagine you're sitting in a restaurant with your loved one Obviously, COVID is gone by then. And you're going to clear your throat 10, 15 times, and it makes people uncomfortable. Aspiration and penetration, obviously, coughing and choking after eating becomes a big problem. So what we know so far is that most radiation studies have shown superiority of chemoradiation therapy over radiation. Minimally invasive and partial robotic approaches are becoming standard of care, and surgery plus chemoradiation has a better disease-specific survival for oropharyngeal cancer. And so therein comes robotic surgery, a good modality to do. And again, a lot of studies have been done, really pioneered, at least in this country, by Dr. Weinstein and Dr. O'Malley, who are at the University of Pennsylvania. We started a program in Boston back in 2007 and have grown from there. But basically, it showed that it had very good local, regional, and distant disease control. Obviously, you can see a lot of these studies from before we started recognizing the importance of HPV disease. And now that we know about it, I think it changes the game even more. There was also transoral robotic surgery for oropharyngeal carcinoma, its impact on quality of life, and it showed there was a positive impact on quality of life. And the whole goal was that even if you do surgery, and there's all these discussions about are we subjecting our people to triple modality treatment or not, and the counter argument to that is the patients are always in for triple modality treatment because salvage surgery is always lurking in the background. As head and neck surgeons, we're always evaluating the patient long term. And if we were not worried about chemoradiation failing, then I think all these surveillance paradigms that we have in different countries and different healthcare systems would be very different. It would be like you operate or you treat someone with chemoradiation and don't follow them out. But you still need a surgeon or someone to be able to follow these patients out longitudinally because we're worried about recurrence. And so, surgery is always there. I always tell my patients, you're always in for triple modality treatment, whether it happens now or it happens a year or so down the road or never happens, I don't know, but we got to keep an eye on you for at least 5 years. So surgery may help de-intensify therapy. I think someone needs to mute. So transoral resection of human papilloma virus, again, these are more studies that show that if you have HPV positive disease, if you did TORS on it plus neck dissection, you improve the disease-free survival, but there's no difference in disease-specific survival or overall survival when you do with or without adjuvant therapy. The E1308 trial was very interesting because we were looking at induction chemotherapy followed by radiation and weekly cetuximab. It was an ECOG-driven trial, and I think it's important to know this because these are the patients who had HPV positive disease, underwent 3 cycles of induction chemo, and complete responders continued on to intensely modulated radiation plus weekly cetuximab. And if you had less than complete response, then you had a bigger dose of radiation therapy with weekly cetuximab. And it showed that the 2 years of progression-free survival and overall survival was excellent in people who had HPV disease. And then you had this new risk group that came in, people who had greater than 10 pack years smoking versus less than or equal to 10 pack years smoking. And you saw that people who smoke less had a better progression-free survival than those who did not. And for favorable risk patient induction, the chemotherapy with reduced dose IMRT with cetuximab worthy of future study. The problem was that there was a release that came out shortly thereafter that people in the cetuximab arm were found to be inferior to standard treatment in HPV positive oropharyngeal cancer. I think this had been published further out, so I think this is something to discuss with our chemotherapy and radiation folks if not already been done. We've moved away from using cetuximab in our head and neck patients, but this is a very interesting finding that I put in here because a lot of the HPV positive patients in our community cancer centers get treated with cetuximab, and we're hoping that that paradigm will change. Obviously, no robotic surgery discussion will now be complete with the ORATOR trial that was completed in Canada and Australia under the leadership of Dr. Nichols up in Canada. And this was looking at radiotherapy versus transoral robotic surgery and neck dissection is a phase 2 randomized trial. They randomized early stage disease, T1, T2, and up to N2 disease, HPV positive into either radiation, 70 gray, or TORS plus neck dissection with or without adjuvant therapy. And they were looking at the MDADDY scores for swallowing at 1 year. 68 patients in this trial. And basically they concluded that the MDADI scores was statistically significant towards having a better outcome in a short follow-up of about 2 years in radiation patients versus TORS patients. Now, obviously, if you look at the schema of the ORATOR trial, pretty much all the patients ended up with tracheostomies who were in the surgical arm. A lot of us don't put tracheostomies in patients because they do fine, depending on how you do, as long as you clip the vessels. But the conclusion here was that we should be thoughtful about favoring TORS over radiotherapy as an initial modality treatment. But I think more studies need to be done to either prove or disprove the findings of this particular trial. But again, important piece of data, at least at this point in time in 2021. The ECOG 3311 trial that was done by Dr. Ferris obviously was a little different. It randomized people based on the risk factor they had after they had TORS and a neck dissection into low risk, intermediate risk. Intermediate risk was basically 2 different radiotherapy arms. One was 50 gray, the other was 60 gray. And the intermediate risk stratification was based on your smoking. If you did less than 10 packs or greater than 10 packs, based on the prior study I showed you. And then the high risk got standard fraction post-operative radiation therapy. And in this, obviously, the important thing was streamlining the credentialing of surgeons. We had to send in our surgical reports, how we were doing it, and about 520 cases were done. 350 eligible patients came out of it. And then Arm A had 37 patients, Arm B had 102, and Arm D had about 110. And then we stratified by risk stratification. Follow-up is about nearly 3 years, and it showed that arms A, B, and C, you had a 2-year disease progression-free survival of greater than 90% in all arms. And especially the important ones were looking at arm B and C, B being where you got 50 gray of post-operative radiation, and arm C being 60 gray. And basically it showed that you had even with, and in low-risk patients, they got observation, which is arm A, that you had a favorable treatment response. And so this tells us that with surgery, we were able to de-intensify treatment and give people a better outcome and reduce their morbidity and de-intensify treatment. So obviously we're here for robotic surgery. It is a balancing act of oncology, functional oncological outcome, functional speech and swallowing outcome, and morbidities and cosmesis. And that's where the robot comes in. The sites you can treat is pretty much all what you can access. Remember, the robot is a play on our traditional surgery with a headlight and electrocautery, with the added advantage of having a 3D camera, which comes in a 0-degree variety and a 30-degree variety, allowing you to look around corners, such as the corner around your base of tongue. So subsites you can work on is, your supraglottis, you can work on the base of tongue, you can work on the tonsil. There used to be a company that went out of business called Med Robotics that used to have a flexible telescope with which you could really look up into the nasopharynx as well. But right now we don't have a flexible telescopic option, but hopefully that'll be forthcoming in the future to take care of that. So these are the main 3 subsites that you can work on. Obviously the cartoons, you have the base of tongue area. We can take out the supraglottis. I've done a full supraglottic laryngectomy with these. We do base of tongue resections. I think it's become a good adjunct in the diagnosis of the unknown primary patient, where you may have to do bilateral lingual tonsillectomies. We do leave behind a strip of normal mucosa in the midline to prevent a complete deficit in the entire pharynx with both tonsils and both lingual tonsils gone. Which would create a stenotic, possibly a stenotic segment. But you can take these out. And really, the robot, again, there are many iterations of it. There's a new version of this coming out as well, which again, we're trying to reduce the size of this, because honestly, a transoral robotic surgery is a natural orifice surgery, as you can see. Both transoral robotic surgery and colon surgery comes through a natural orifice, unlike our partners in urology or general surgery, where they're insufflating an abdomen and operating through it. So basically, as I joke around, we really rely on people with big mouths and ideally with no teeth. Those will be the ideal candidate for this surgery. but you can fit in three arms in this. I think with the newer iteration of the new robots coming out, you can have 4 arms coming through a single arm, sort of spreads out like the legs of a spider, which will be very exciting to use. I have not used one of those, but enthusiastic about getting my hands on one of those. And really, the advantages of robotic surgery is superior exposure. You can do 360-degree movement of an arm. You can have your wrist motions magnified based on how you set your robot. Magnification, obviously, is like getting a microscope into the throat. Allows you to really come up close and personal with the tumors and to see them. There's better illumination. And honestly, if you can take the tumor out of their mouth and not do traditional mandibulotomies, or other procedures, then the patients will have a shorter outcome or recovery to swallowing. Disadvantage is obviously there's a learning curve. You got to learn how to use this. There's a big capital expenditure. I think the new iterations of some of these robots is $2 million or more. And there's disposables as well that you need to look at. It is difficult to manipulate for anterior lesions, so really want to use stuff in the back of the throat, such as tonsura fossa, base of tongue, supraglottis. But again, we always do a pre-TORS endoscopy where we just assess if the patient will be a candidate for the robot. I think this is also because we share the robot amongst multiple specialties. So it's just unfair for us to say, hey, we're going to use a robot and then go in, figure out, oh my God, this doesn't fit in there. You just prevented another service from choosing the robot that day. So I think in the interest of shared resources, we use that methodology to see if the patient would be a candidate for robotic surgery at the time of their staging endoscopy. When I first started this, we were doing this on an IRB protocol, which is obviously now long done. FDA approval was obtained in 2010. We did staging endoscopy for everyone. And then the TORS experience, our experience has been great. Our average length of stay is just over 3 days. Surgical time, once you get used to it, the docking and getting this done, you can get out a base of tongue or a tonsura fossa with some trained hands trained hands in under an hour. Blood loss is low, and the swallowing recovery is usually in 0 to 2 days. I typically feed my patients pretty much right after the surgery. We do keep them at least overnight or 2 days just to make sure they're doing okay and their airway is okay. We had done our initial study was looking at 2-year survival, and we saw that TORS dysfunction in our patients was about 30% of the TORS, and 47 or 50% people who underwent TORS with adjuvant therapy, because we were seeing at that time that we were saving people from getting adjuvant therapy at that point in time. Dr. Manick, are we on time, or do I need to? I'll be wrapping up pretty soon.
I got another 4 minutes. Yeah.
Okay, perfect. So we learned some important lessons, and if anyone's starting these TORS programs early on, I think you have to have a team. You have to have surgeons who are learning. I think learning together with another consultant surgeon is very, very helpful. Having a trainee team is important because that's the way forward to pass this on to the next group. But I cannot understress the importance of having OR staff that can work with you, because there's a lot of issues with logistics. Who's going to set it up, initial setup, prepping, stuff like that, docking. I think having a really good nursing and OR tech team is very invaluable. And at the same time, they also become a great resource for training the next group of surgeons as well. Shorter length of stay. So really, in conclusion, over here, HPV oropharyngeal cancer increasing, especially in the younger adult. They do have a better prognosis. It is a reduced recurrence despite extracapsular extension. And I think de-intensification therapy is needed to prevent long-term sequelae of traditional therapy. I think there's a lot of data out there now looking at, or actually it's more interest in data about the swallowing outcomes dating back to over a decade ago, and more recently with the ECOG 3311 trial and the Orator trial. So I would highly encourage people to read that data. Robotic surgery, like we said, through a lot of the data we've talked about, can de-intensify treatment. It does require appropriate training and credentialing programs. I think our speech language pathology folks, through their research, have shown that if we can reduce the amount of radiation to the constrictors, and a lot of studies was done by Dr. Susan Langmore, who was at Boston University, and prior to that at UCSF, in University of California in San Francisco, that if you can reduce the damage to the constrictors, it can have a huge long-term impact on the patient's functionality. I think more studies need to be done about functional outcomes of TORS versus radiation. I think the ORATOR trial, which is has opened our eyes, is towards the cure-all for everything. I think all information should be discussed in a multidisciplinary head and neck tumor board so that we can reach a consensus discussion. But I believe robotic surgery, just like other minimally invasive therapies, is here to stay. We should embrace it, see how we can apply it appropriately to our patients, be honest about outcomes, and then go from there. So I think that's about it. We wrote a whole book about robotic surgery of the head and neck. There's a lot of stuff in here if anyone wants to do, including how to set up a new program and so on and so forth. Really amazing co-authors on this particular book. This is our sprawling campus at Beth Israel Deaconess Medical Center at Harvard Medical School. I welcome anyone. I'm hoping travel is going to start soon because I sure miss it. It'll be very much more fun to be sitting together, having lunch or something like that, or dinner with these meetings. But I think we missed that. But hopefully they'll come on soon. So I invite anyone to come and visit us once things open up. But thank you very much for this opportunity. Really thank the ENT head and neck entire committee that organized this summit, particularly Dr. Manick and Dr. Majumdar for inviting. Thank you very much. And I don't know, we take questions on chat, or how do we do that?
Brilliant. I think there's one question. Scharukh, there's a fantastic evidence-based talk that's really good with lots of papers and research evidences. The question was, before robotic surgery, do we need to do tracheostomy, or it depends?
It depends. I think our tracheostomy rate is extremely low. I think that's where I always say this surgical judgment and selection becomes important. Obviously, if someone's coming in with a T4 tumor invading into the pterygoid with trismus, that's not a person you're going to do for robotic surgery. But we have probably just done a handful of tracheostomies over the last 10, 15 years, since 2007. So whatever that is, nearly 15 years. But I think the patient selection is important. I think too many people early on, that's what I told you in the lessons learned, is early on we were doing stuff. And then when we look back, we're like, were we stupid to think about trying to get this done through a robotic surgery? Those are the people who probably need an open operation in which you would get a tracheostomy. So I think if you can come up with a paradigm on patient selection in your units or in your communities, I think it'll make life much, much better. So yeah, we do not do tracheostomies as a routine.
Good. How would you assess a potential extracapsular spread preoperatively? Is it by a gross late ECS clinical signs like fixation or skin changes, or radiologically, or both?
So that is a very good question, because historically, when you're on our tumor board and you talk to the the neuroradiologists, they would say, "Oh, I think there's extracapsular spread," and that's why the study I pointed out to, that really extracapsular spread, when you talk to a pathologist, is a post-surgical diagnosis. Although over years we had come to this conclusion that we can detect extracapsular spread. And we've seen with HPV disease that when you go in, and I'm pretty sure you guys have had this experience as well, that you go in, you take out something that was billed as extracapsular spread, and pathologically now there's nothing. And so that is a value of surgery. That's what the message I was trying to send in the earlier slides, that is a value of surgery to give a more accurate staging of patients. I think extracapsular and extranodal extension is a pathological finding, and by definition, that should be post-surgical. But there are plenty of people that we see who are sent to our center for salvage surgery, where when you go back in time, patient was labeled with this and that HPV positive disease, and they said there was extracapsular spread, and now they're suffering from the outcomes of high dose chemoradiation, because some of our community centers go to as high as 74 gray on the radiation for primary treatment, and then our laryngologists have to deal with them. So I think this is very important. It's actually a very important question, and I hope that with time, we come back to the pendulum that surgery is an excellent tool for improving our staging paradigm. I hope that answers that question.
That's absolutely right. I think some of my friend from Birmingham, the head and neck surgeon, he also kind of reiterated case selection is important, particularly considering the Pathos trial, which is actually run by Liverpool Group. That's really, really good. Thank you very much. That's absolutely a fantastic talk. Thank you very much for your valuable time, Scharukh.
Thank you so much, Jay. If there's no other questions, have fun. Everyone stay safe. If you haven't been vaccinated, try to get vaccinated. Thank you, Sam.
Thanks. Thanks very much.
Can
I just quickly ask you one question? I love listening to your talks. You're like a walking encyclopedia, and I totally love it. But this radiation to constrictor muscles, and that that is a very, very important point. Is the outcome of swallowing dysfunction after radiotherapy is often very overlooked, and I'm so pleased you mentioned it out there.
Yes. So Sam, actually, another question, just to push that a little bit forward. I know you're short with time. Another question from the surgical standpoint, which I was actually discussing with my fellows and my residents last night, literally, we just did a robotic case, is the aggressive surgical, how aggressive people can get with poor surgery. And we have to keep that in mind. Is that aggressiveness worth is there any survival benefit? And I think we're going to start looking at that, because depending on what TORS courses you go to, there are TORS courses that say, absolutely, you have to cut down to the styloglossus, the palatoglossus, you got to expose it, you got to expose the glossopharyngeal nerve. In our unit, we have not seen that. We think as long as you can get through the constrictor, get a sliver of constrictor and peel it off, get into the parapharyngeal fat, people really do well. So that's something I think we're going to look at and see if that much aggression is truly needed. And I don't think anyone's answered that question. So if anyone on this wants to do maybe a multi-institutional trial, I would love to work with you guys, because I think there's an important question for us as surgeons to evolve in time is how aggressive is too aggressive, or at some point you're doing the same as wide open surgery, are you helping them? But the constrictors, and Dr. Majumdar, they're very skinny, they're very flimsy.
Brilliant. That's great. Thank you very much.
All right, thank you guys. Carry on. Thanks for inviting.
Thank you.
I'm going to sign off.
Thank you, Scharukh.
Bye-bye.
Thank you.
Thanks, everyone.
Bye-bye.
Okay, Mr. Nixon is going to give a next talk, and he has kindly pre-recorded the talk, but he's also available. Mr. Nixon is one of my good friends. He's a lead head and neck consultant from Edinburgh. Is very knowledgeable, and his practice are very much evidence-based, and his talk is more about parotid. It is actually very...
Okay, hi. My name's Iain Nixon. I am hopefully recording this lecture on parotidectomy. You might question, why am I going to talk about parotidectomy? And this is aimed largely at an ENT audience at a trainee level. And I just want to share with you my thoughts about how we approach parotid surgery. Because my opinion on it has changed quite a lot since I got to the last few years of my training. And I think it's worth thinking about if you're going to be a head and neck surgeon. And many people, you don't have to do malignant work, but parotidectomy is a nice operation. And many people will do this when they qualify whether or not they're a dedicated head and neck surgeon. So if I can get this to work. First, we maybe touch on why we do parotid surgery. Well, most people will be familiar with the most common indication, which is for benign disease. Very rarely it's done for inflammatory benign disease, but it's more commonly done for tumors. And of course, the most common of those is pleomorphic adenoma. But we also do it for malignant disease. We do it occasionally for lymph nodes and metastatic lymph nodes or lymphomatous lymph nodes. And also, of course, for primary parotid malignancies. And these are really the main indications for parotid surgery. Occasionally there's stone surgery, but that's pretty rare. Now, I think it would be sensible if you're going into the exam to be aware of the European Salivary Gland Society classification, 1 and 2 being the superficial inferior, superior and inferior lobes, 3 and 4 being the deep lobes, and 5 being an accessory lobe. And I think that's a reasonable classification to be aware of, at least going in. But I don't really want to labor on this because I think about parotid surgery rather differently. Now, you've probably been involved in parotidectomies, and surgeons may have called them extended total parotidectomies. That generally means that you take the parotid and surrounding structure, skin or masseter, or sometimes temporal bones and things like that. A so-called total parotidectomy generally refers to resection of superficial and deep lobes, although because the parotid doesn't really have a nice capsule, particularly on its deep aspect, there isn't really such a thing as a total parotidectomy. Nonetheless, that's what it tends to refer to. Deep lobe parotidectomy tends to mean that you mobilize the superficial lobe and take the deep lobe. Superficial parotidectomy tends to mean the opposite, that you mobilize the superficial lobe only. Then you'll hear people talk about partial superficial parotidectomy. That tends to be where you take part of the superficial gland, but not the entire superficial gland. And then there's this other term, extracapsular parotidectomy. And really, I'm going to talk about these different variations and how there's quite a lot of similarity despite the range of names that we use. So what are we doing when we do a parotidectomy? Well, we're obviously aiming to remove disease. And as we said, this is largely done for pleomorphic adenoma. And you want to minimize the chance that that comes back. But at the same time, you want to minimize the risk of injury. Now, we would all recognize that facial nerve injury is one of the risks of parotid surgery. But there's potential injury to sensory nerves that can leave people with chronic paresthesia or pain. There's the potential for Frey's syndrome. This is gustatory sweating because of the innervation of the sweat glands in the skin rather than the salivary glands in the resected lobe. And, perioperative complications like salivary collections and fistulae that can develop after surgery. Now, if you think about how we got to where we are now, I think this is a useful way to think about why we do what we do. Historically, before the era of reliable, safe anesthesia, in a time where there wasn't electrosurgical hemostasis, enucleation was the preferred way of getting tumors out of the parotid. Generally, surgeons would make an incision directly over, and often they would use something that looks like a tiny ice cream scoop to actually scoop out the tumor in order to debulk it fundamentally, trying really to stay on the capsule and do this enucleation. Unfortunately, that was associated with high rates of recurrence. It's quick, it's relatively easy, but there's no identification of the facial nerve. And in particular, there was this problem with high rates of recurrence. And so surgeons recognized that there was interest in the histology of the lumps that were being taken out. And of course, they were pleomorphic adenoma, exactly as they are today. Now, the understanding of pleomorphic adenoma has evolved over the last century. It's well recognized that this is a benign condition, although there is an association with malignancy. We teach generally there's about a 1% per year risk. So if you leave it for a decade, there's a 10% risk of malignant conversion. That's probably an overestimate. It's often quoted, but it's not really based on much science. Data from Scandinavian registry suggests probably it's a bit lower than that. Maybe there's a 5 to 10% lifetime risk of conversion. And you should bear that in mind, particularly when you're counseling patients about the overall risk. I find that in a young person with difficult to resect recurrent disease, you've really got to think carefully. The risk of conversion is low, but it is present. But the reason that pleomorphic adenoma is locally recurrent is because of this so-called pseudopodia. So the tumor itself lacks a capsule, and as a result, the stroma of the tumor can come out through the holes in the capsule and create these little feet or pseudopodia. And when you slice through them, they sometimes look like satellite lesions. And I think there's disagreement about whether they are actually connected to the primary or whether they're separate little lesions separate to the primary lesion. So you can imagine if you just simply scoop the capsule out, then potentially you leave these little feet of tumor and they are in a position to recur. So as a response to the improved understanding of histology, and at a time where anesthesia was improving, understanding of anatomy was improving, and as we say, histology was better understood, surgeons changed their practice from the simple enucleation, and they were really tried to start maximizing the margin that they had on the tumor resection and prioritizing protection of the facial nerve. And the idea was to produce a procedure that could easily be taught, which helped minimize the risk of recurrence. And that led to the development of superficial parotidectomy. And this really has become the standard of care, and it's important that you know how to do this if you're training in ENT. It's a reliable and safe operation with excellent outcomes. So if you're thinking about doing a superficial parotidectomy, and I'm going to come back to this image a few times, this is roughly where the parotid is. The bulk of lesions will be just below the earlobe in this kind of area. And the incisions that we use, I personally use a modified Blair incision, which is like a kind of a lazy S or whatever, down pre-tragal. You can actually go behind the tragus if there's no crease, and up onto the mastoid and down into a skin crease. Although it is also possible to do this via a facelift incision, which is thought to be cosmetically superior, but very difficult to teach somebody that. They're retracting the flap and can't see really what you're doing, which makes it, I've never really done that. But these are the workhorse incisions for superficial parotidectomy. When you do this procedure, maybe I don't need to go through this, but you make your incision, you raise a subplatysmal neck flap, and then over the face, you lift the flap over the parotid fascia. I then, once I've raised the flap, I identify the anterior border of the sternomastoid, trace the anterior surface of the posterior belly of the digastric up the way. So that's really approaching the nerve from below. And from above, mobilize the gland off the tragal cartilage. And really you're looking for the main trunk of the facial nerve then. It's somewhere below the tragal cartilage and above the digastric, and it kind of subtends an angle between the tragal pointer and the digastric. And I always think this is quite a nice bit of a procedure. You slowly dissect the gland off the stylomastoid foramen until you come across the nerve, and you use these things, the tragal pointer, the digastric, and the tympanomastoid suture in order to identify the nerve. And that's really a reliable, fairly easy way to do it. You need retraction on the gland, and you'll come across the main trunk of the facial nerve, which can then be followed out through the gland without rupturing the tumor. And then once the tumor is delivered, you achieve hemostasis, which you should have been maintaining throughout, really. Most people would use a drain. Obviously there's ways of doing it without drains and fibrin glues and compression and so on, but most people use a drain and then closure whatever way you like. So it's a good procedure. It's one that you should know. It's safe and it's reliable. And it's the standard of care for benign tumors of the superficial gland of the parotid. Now, if we look at the parotid gland anatomy as a kind of schematic here, on the lateral view, I think everyone's familiar with this. The tail of the parotid can be peeled off to find this main trunk. And then you have this branching structure where the so-called pes of the gland, the goose's foot splits in two, and then they further split in two, and you have these 5 branches, classic branches. When we look at it in an axial plane, you can't see it on a CT scan. Of course, the retromandibular vein is the marker on radiology, but it trends from deep to superficial as it courses through the parotid gland. And so therefore, this is what we're talking about. This is the superficial lobe of the parotid gland, and that's what you're trying to remove with a standard superficial parotidectomy. So permanent nerve injury is rare. It's not too difficult to find the nerve. But in fact, temporary nerve injury is very common. This is probably because of the traction injury, particularly on the marginal mandibular nerve, as you fold the skin edge forward and then you're tending to be retracting everything superiorly. And certainly in my hands, about a third of patients will have a temporary weakness of the lower lip. But what you do with this procedure is you maximize the margin. It's also a very easily teachable procedure because there's nice logical steps, there are landmarks, and these are the kind of things that make operations possible. Without these, very difficult to teach procedures. So that became the standard of care across really modern medicine and surgery. Superficial parotidectomy became the workhorse operation for benign tumors of the superficial gland, but not everyone agreed that it was the right approach. There are some significant downsides of superficial parotid surgery. It's disfiguring, and it's a difficult thing to explain to a patient, but you lose a significant bulk of tissue behind the mandible. You get a dent behind the mandible, between the mandible and mastoid, because you take quite a chunk of tissue out. There's this association with Frey's syndrome, where you get postganglion innervation of sweat glands. And depending on what you believe, almost 100% of people get some demonstrable evidence of that, although much lower rates of complaint about it. Maybe, I don't know, somewhere between 10 and 30% of patients will notice that after a full superficial parotidectomy. But what I really want to focus on is the question about whether the margins argument is valid. Because what you'll find if you do parotid surgery is that the vast majority of tumors will abut the nerve at some point. And as a result, the positive margin rate in parotid surgery, if you look back through your parotid specimens, almost 100% will have a positive margin somewhere, and it will be where the tumor abuts the nerve. And so even though a large margin is taken, if you think of margins as binary, as positive or not, positive or negative, or even if you think of close positive or negative, then what you'll find is that the vast majority of parotid surgeries result in a positive margin. And so an alternative approach was championed by maxillofacial surgeons, and in particular coming from the Christie Hospital in Manchester. Now, again, I've drawn a schematic here of a parotid gland, and I put the mythical nerve here. That's the plane of the nerve. So the normal tumor will be something like this. It will be a benign tumor within the parotid, and it will tend to abut one of the branches at least of the facial nerve. Now you can see here, if you do a superficial parotidectomy, you dissect along the nerve here on the red plane, and the entire superficial lobe is as a result excised, and you get a great margin here, you get a great margin here and here, but on the deep surface, you will tend to get a positive margin. You can see this is in contrast to enucleation, where you simply cut straight down and just scoop this thing out. But the Christie argued that there was another way to do this. And yet the extracapsular parotidectomy is not an enucleation. It's an attempt to excise the tumor with a narrow margin. The way you do this is you cut through the parotid fascia. Really, you raise flaps exactly the same way as you would do for a standard parotidectomy. You then cut through the parotid fascia down towards the tumor. And in fact, you make a cruciate incision in the parotid fascia and you fold all four sides of that back. And then you're generally looking at the tumor encased in salivary tissue. You then gently dissect around the tumor, aiming not to see the tumor at all, but to leave a few millimeters of tissue all the way around. You dissect around both sides, and on the undersurface, you will tend then to find this positive margin abutting the nerve. When you start doing this, you think, I'll never be able to find the facial nerve. In practice, what you actually find is that you don't have to cut very much salivary tissue. It tends to fall apart on you. And that as a result, you're hardly doing any sharp dissection at all. And when you come across the branches of the nerve, you will see them. And so this is an extracapsular dissection. And when you've removed that, the tumor goes off for histological analysis. and you're left with a cavity within the parotid. But in practice, you suture the parotid fascia back together, and it results in a much smaller specimen, much less cosmetic defect, and indeed, much less chance of Frey syndrome, because as the postganglionic salivary fibers enter the deep lobe and course up towards the surface, they hit the intact parotid fascia and can't get through. So yeah, as I said, what we tend to do, that's where the circle is slightly off here, but we raise a subplatysmal flap, raise the fascia, you palpate the mass, we tend to make mark a cruciate incision, which is 1 centimeter beyond in all 4 dimensions the mass itself. You make the incision, you hold the edges with clips, otherwise they tend to fall apart a bit, and you dissect through parotid around the tumor and remove it with a cuff of normal tissue. And if you stick to this rule, you never divide something you can't see through, fatty salivary tissue, you cannot see through nerve. And if you do that, you will not cut the nerve. You will identify it, and in the vast majority of cases, you'll end up following a branch for a centimeter or so as you take it off the tumor. And then, of course, you do your hemostasis, close the parotid fascia and the skin. So the arguments for extracapsular dissection are that you have significantly less tissue loss. You close the capsule following the resection, which reduces the Frey syndrome risk, and you don't expose the main trunk of the nerve. So there's a number of reasons that might be advantageous. Obviously, if you don't expose it, there's less potential to damage it. To be fair, damage to the main trunk of nerve is rare after standard superficial parotidectomy. But also, if you ever did need to go back for recurrence, it would mean that the main trunk remains virgin territory if you had to go back there, because we've not identified digastric, sternomastoid, tracheal pointer, nothing like that. You dissect straight down on the tumor. As a result, it's much less injurious a procedure. It's a shorter procedure, and the vast majority of these I would do as a day case procedure without a drain. And really, it's quite a minor procedure in comparison to superficial parotidectomy. There are, however, arguments against it, and it's said to be difficult to teach. I have to say, I am not sure that's true. People say that, and they say it's only safe in the hands of an expert. I learned from a guy in London, and he was, I think, really, truly an expert in doing this. But even in my hands, I have not found this to be particularly challenging. You just take your time. If you list it for a superficial parotidectomy, you probably give yourself 3 hours, and I tell you, this takes you more like 90 minutes. And much of that is closing the wound at the end. So you've got plenty of time not to rush and slowly, carefully take it out with a small margin. Of course, you do get a smaller margin. And there is an argument that that's associated with higher rates of recurrence. There's also a question, what do you do if you got the diagnosis wrong in the first place and it comes back malignant? Because that makes an awkward MDT discussion. So I think patient selection is important. So I would tend to favor a superficial parotidectomy for larger tumors. Now in practice, if you've got a 3 or 4 centimeter tumor in the parotid, by the time you do an extracapsular and take a margin around it, you're going to be exposing most of the facial nerve, and I think it's probably safer and less controversial just to do that straight up superficial parotidectomy, find the main trunk and trace it out. Also, if there's any suspicion of malignancy, I think that's also the right thing to do. Or if for some reason margins are critical, and I normally have the conversation with patients if they're able to comprehend the level of complexity. There will be, for example, the parotid tumor found in workup of a breast cancer, and a patient will be very aware that in breast cancer margins are critical, and they will apply the same thought process to their parotid. And so I think you need to be careful in counseling your patients and making them aware that superficial parotidectomy really is the standard of care. I go back to this malignancy issue, that if you think that the tumor may be malignant, and there's a number of ways you might think that. Obviously, if you have metastatic disease, there's no controversy. If you have a biopsy suggesting it's malignant, again, really no controversy. But occasionally you will get suspicion based on clinical findings. You know, if you think it's tethered, if you think it's pain, if the patient reports pain, or if the biopsy it's not conclusive and it says we can't exclude a malignancy, something like that. If you end up with a malignant specimen and you go back to your MDT, the question, you will always have a positive margin because you always do whatever you do, you will have a positive margin. Remember that, because the MDT considers a margin binary. And the oncologist will say, is there any more you could do? And the truthful answer is you can do more. If you've done an extracapsular, you can do more. You can go back and do a superficial. That's really a painful thing to have to do without any evidence that there's benefit in that. But that's a difficult problem. And so as a result, I think if you're worried at all, superficial parotidectomy should be your go-to procedure for large or potentially malignant lesions. So I think an extracapsular dissection is best for smaller tumors, obviously, and those ones that are nice and mobile within the parotid. Or if for some reason cosmetic outcome is critical, if reduced operative time is valuable. Now, actually thinking of patients who are comorbid, although we don't do many pleomorphics in patients who are critically unwell, or if for some reason minimal tissue trauma might be beneficial. And I've tended to recommend this, for example, in patients who have chronic pain. So I have operated on a few people with chronic pain syndromes. I guess they get more frequency of scans and you pick up benign things here and there. And I think because of the minimal tissue trauma, they're less likely to have a pain response, because I do have a few patients who've had superficial parotidectomy and really find a lot of discomfort post-operatively in the long term. So one of the reasons that you might say you don't want to do this is that in ENT, we say you can't. The extracapsular dissection is not an operation that's regularly taught in ENT. And I didn't even hear about this until well after my exams when I was doing fellowship training in London. But I'm going to make the argument that even though we say we don't do this, in practice, we kind of do. So if Prof says you can't, you don't necessarily need to listen to him. Because probably Prof does it himself, but doesn't admit to it. Because if you think about the fundamental difference, superficial parotidectomy is basically finding the main trunk and following it and excising the superficial lobe, whereas extracapsular, you make no attempt to find the main trunk, you simply excise the tumor. But I want to look at some examples of parotid tumors schematically and think about what we actually are going to do. So here's a central mass, right? And this might be the typical pleomorphic adenoma. And in this, really, you have these two options. This is the same diagram on its side that I showed you in the earlier slides. And you have these two options of going in and doing an extracapsular versus a superficial parotidectomy. So you choose what you think is reasonable. But superficial parotidectomy, let's remember, really the definition is that you remove the entire superficial lobe. Now, let's take this example. This is not uncommon to see a tumor hanging off the inferior border of the parotid. Often you wonder if these are actually submandibular. Now, there is almost nobody who would say that they would go and do a full-blown superficial parotidectomy. Because if you think about the practicalities here, if you make your modified Blair incision, as we said, you raise your flap and you go down and find your digastric. By the time you've found your digastric, this tumor is hanging in the wind and it's actually almost out. So the majority of people here wouldn't go for, it's hard to believe that removing the superior tip of the superficial lobe, what do we call that? Level 2 in the European classification. That does the margin at the top end of the parotid matter in this that's hanging off the bottom? Because you're not going to take, for example, even if it abuts this submandibular gland, you're not going to take the submandibular gland as part of this. You're going to accept a positive margin on the edge here. And most people would tend to make a submandibular incision, find the marginal mandibular anteriorly, trace it back, fold the tumor off, and say that that would be the retrograde approach to a low parotid mass. Even though when they lecture on it, they would say, oh, you always do superficial parotidectomy for superficial tumors. Let's think about one that's hanging off the back of the gland. And when you do these operations, again, we think of our modified Blair incision, and then you're trying to get down to the sternomastoid. And in doing so, if this is superficial to the sternomastoid, as the tail of the parotid is here, again, the tumor's out before you've dissected anything. And so this concept that you're going to go down and find the main trunk, most people wouldn't do that because the tumor's already out. We're not going to sacrifice sternomastoid for a margin, so why would we sacrifice the rest of the gland? And although that's neither of these are classic fascial opening extracapsular parotids and closing, we are not found the main trunk of the nerve, despite the fact that people who do this will often say they would not do an extracapsular approach because you have to find the main trunk. Now, what about the very anterior? So again, this is a kind of controversial thing, but you're not going to take masseter. Nobody takes masseter. You're not going to do an outer rim mandibulectomy for a pleomorphic adenoma. What you're actually going to do is you're going to raise the flap here. You're going to follow it anteriorly. And probably you're actually going to look for the buccal branch at the anterior aspect, and you're going to dissect this thing off the buccal branch, because it is hard, again, to believe that sacrificing a huge chunk of parotid for what is really an accessory parotid tumor here is worthwhile. And so, of course, we also see these deep lobe tumors. Now, people have different opinions about this, but here we're going to follow the nerve, we're going to fold the superficial lobe forward, and then you're left with a tumor in the deep lobe, which abuts the nerve. Inevitably, the nerve is dissected off it, the tumor is delivered, you get very little, if any, margin on the deep aspect of the parotid, and then you're left with the question, what do you do about the superficial lobe? And many people will fold this back in the belief that that will reduce Frey syndrome and minimize cosmetic defect, and you're already got a positive margin on the nerve and on the deep aspect of the deep lobe. So the reason I show these is that I think that although if we go back to this standard one, there is this in some ways is the most contentious one, because you could do either a superficial parotidectomy or an extracapsular dissection. But in practice, what most people will do is they won't do a full-blown superficial anymore. They'll find the main trunk of the nerve if they're going to do a kind of facial nerve approach to this tumor, and they will trace it. And generally, you'll find this will be on the upper or lower, normally lower branch of the facial nerve, and you'll be able to sacrifice only one subsection of the parotid in doing a partial superficial parotidectomy. And that's largely what the standard of care has now become, excision of part of the superficial lobe. So surgeons are already accepting that you don't need these huge wide margins, even though superficial parotidectomy in the textbooks is the standard of care for benign parotid disease. So my approach to this has changed, and it changed really because I was introduced to this concept of the extracapsular dissection. My colleagues tell me that whoever takes over my job when I retire will be taking out my recurrences, and we'll see if that's true. But certainly the Christie published 1,000 consecutive cases with no higher recurrence rates. Recurrence rates are very low, less than 5% over the next 20 or 30 years. And really there's no evidence to suggest that superficial parotidectomy, it reduces that. There's bias in series and so on, as I've discussed. But I think at least if you're going to embark on a career in parotid surgery, you should be aware of this as a technique, and we don't particularly teach it well in ENT. And so, well, as I come to summarize, and I know we'll take some questions, that the approach to parotid surgery has evolved, and it's evolved partly in line with anesthetic improvements and electrosurgical improvements, but also with our understanding of histology. I think if you're going to approach parotidectomy, you need to be adaptable. There are conservative operations like extracapsular dissection, retrograde approaches to the nerve in inferior and anterior tumors. You might even accept not identifying the nerve in small tail tumors. There are standard approaches. The superficial parotidectomy is a great operation, gives you a great margin, and it's very difficult to be criticized for it. You can be radical when you need to, doing extended parotidectomies and so on, but we didn't really want to talk about that today. I just wanted to talk about the standard approach to parotidectomy. We need to be aware that there are risks to the facial nerve, risk of phase syndrome, cosmetic problems, numbness and pain can be a problem post-operatively. And these in some ways relate to how you approach the parotid surgery in the first place. And we aim overall to minimize the risk of complication, but also minimize the chance of recurrence by doing a good parotidectomy.
Thank you very much, Iain. That's really a fantastic lecture. I really liked your schematic diagram. I think it's a very artistic lecture, that's what I would say. Even parotid surgery, I consider is a kind of a design surgery. You need to tailor your approach or operation according to the patient and disease. I have no objection for extracapsular dissection. I think there is a lot of evidence there. There are some questions in.
Sure, I see that one coming up about whether there are risk factors for formation of siloceal. Right. Yeah, you see that? I think something like 10% of patients develop a salivary collection after surgery, and that can become a fistula. And I don't know offhand if there are known risk factors, but I think this is one of the things I'm starting to see with extracapsulars is that you leave a lot of parotid tissue behind because you take a lot less out. You know, if you do a radical parotidectomy, a patient's never going to get a siloceal because there's no salivary tissue left. Whereas if you do if you do a small resection and leave a large part of the native parotid there, then I think you're actually at higher risk. I think the worst one I've ever had was I did with Panos actually. And I think we may have tied off the parotid duct. And I think one of the reasons you get siloceals is that within the parotid, you get edema following the surgery. And that forces close the salivary ducts. And then gradually, as the edema settles, the ducts open, and then it can flow again. So everyone gets a bit of a collection, but it doesn't. As long as you've got a decent drain. Do you remember that one, Panos?
Yeah.
I think that's probably one of the reasons. But the good thing about siloceals is they always eventually give up and settle spontaneously. Is Jenny going to tell us the answer?
No, Iain, I think we're at cross purposes here. Sorry, Jai, I never got the Zoom meeting link, so I'm piggybacked on information from Jenny. All I was going to do was firstly congratulate Iain on his COVID haircut. Good effort.
Thank you very much.
And then secondly to say, I guess we've been doing it for about 6 years now. I think it's immediately prior to coming to the QE, and I haven't had any problems with long-term sialoceal in my personal practice. And then I guess I know that you had said that your successors would, in the view of their critics, carry on taking out recurrences, etc., after your retirement. But I mean, my point is that we don't know what causes benign parotid tumours, do we? And if you leave pretty much 100% of the parotid behind, which is good for the individual in terms of lessening the impact on quality of life and contour of the face is better, chances of facial nerve injury are reduced, that they've still got lots of parotid in which to get another tumour. And it's surprising maybe that the incidence of second benign parotid tumours isn't higher. It's really encouraging that it's not. But I think there's a perfectly fair answer there, and it's not related to your surgical technique at all.
Sure. And there's a very well recognized recurrence rate after superficial parotidectomy anyway. And I think when you've done a few, you start to get a feel for just how much less morbid these are. And they're not suitable for big or suspicious tumors, but for small tumors and selected patients, I think they do have a role. Do we have any more questions? Yeah.
Can I ask a question? When sometimes you have a pretty big cavity there and you bring the fascia forward to close it. And do you ever put any kind of hair cloth or anything to kind of make the cavity, to reduce the dead space, to prevent sialosyl, or any synthetic materials? Does anybody ever use that? Or try to suture the parotid together? Because it's quite flimsy to suture the parotid together underneath the fascia. The actual parenchyma, I find it very, very flimsy.
Even after a superficial?
After an ACD, an extracapsular dissection.
Well, I try to leave the capsule intact and suture that back together. And I make this kind of cruciate incision and then put an artery clip on each corner, really just so at the end you can go back and find them, otherwise they disappear. I personally haven't used fibrin glues and so on. I know someone who's a big fan of them, just slightly to the north of me, who probably has something to say on the use of fibrin glue in parotid surgery.
That's true. I absolutely allow the fibrin glue. Not only me, there is a systematic evidence review as well as meta-analysis clearly shows there's a lot of benefit. It's cost effective and with a high patient satisfaction, and it enhances more day-case surgery. And for Pana's question, sometimes I do make a split incision in the sternocleidomastoid and just pull it medially to obliterate the cavity. So that it works. But there are reports you could divide the medial, lateral head of the digastric, detach it, and just make it kind of rotate it on one flap. But I don't find it that's very useful, and patients don't mind from our centers. I'm not really sure about other areas. Brilliant. So that's great. Thank you. So we'll have a short break, 10 minutes coffee break. Then after that, we have 3 more talks, including my talk and Jenny's, as well as Shiying. Thank you.
It's going to be a long day, Jay.
You're catching up to a few minutes.
Are you running a bit late, are you?
Yeah, we are just trying to, we are shortening the coffee break for 10 minutes.
Yeah, it's difficult, isn't it? Because I have been with Scharukh a few times, and he could talk forever, and he has so much to share.
Jenny, are you around?
Yes, I am. Can you hear me?
Great. Do you want to try and share your screen?
Yes, I will try my best. Okay. Share my screen. So is that okay?
Not yet.
Oh. So I've got an option of desktop 1, whiteboard.
Just go for a desktop.
Desktop 1, okay.
You can see your screen.
Can you see my slides?
And you need to just put slide or slideshow.
Slideshow. How's that?
Perfect. It works.
Is that okay?
Fine. Do you have any movies or voice? I think it works well. That's fine.
Sorry, I didn't catch what you said there.
Do you have any kind of movies inside as well?
I've got one video.
That's fine. Is it with the voice?
No voice. It's a silent one.
That's fine. That's good.
Perfect. Thank you.
So, sharing the screen. Yeah.
So I'll stop sharing just now.
I think after my talk, you will talk, I think.
What do I press stop video?
It's don't worry, I'll disable because I'm going to.
Can you disable me? Stop share. Oh, sorry. I just saw the button there.
I've done it for you.
Thank you.
Welcome back. So I'm going to talk about management of early laryngeal cancer with a particular focus on laser surgery. So here we're going to discuss about some management options for early laryngeal cancer and techniques of laser surgery and some evidence. Why it is important, transferal laser surgery or laryngeal cancer? Nearly 2,400 patients diagnosed with laryngeal cancer every year in UK. 800 patients die of the disease per annum in UK alone. So laryngeal cancer is one of the disease burden for head and neck. As we can see, there is a clear distinction between early laryngeal cancer and advanced laryngeal cancer. We have discussed about the glottic cancer staging. The clear distinction is T1, it's involving one vocal cord, or maybe once, but it can be both vocal cords, that's T1B. And T2 is easy, a little bit going above and below, subglottis or supraglottis. And T3 is important because it's vocal cord fixation, radiologically a paraglottic space invasion, or inner cortex of the thyroid cartilage. That's again, it's important finding. T4 is advanced with particular extension to the strap muscles and cricoid cartilage on thyroid cartilage through and through. So we have three distinct management options for early laryngeal cancer. So the bottom one is actually in Lanzarote is a natural volcanic oven, which is helps with to kind of roast the chicken within 20 minutes. This is electric, and this is Scottish wooden frying or roasting. But laser surgery is economical, convenient. You can repeat as many as time. It needs a unique skill set, but it can provide a superb outcome. Radiotherapy is equally good, but it is a one shot. It's long, like 5 to 6 weeks duration, and the side effects are still there. And partial laryngectomy, it is again unique skills with a particular focus in some centers, and eventual laryngeal preservation also high. The viewpoint is very important. I feel sad sometimes why we are not doing enough laser surgery for early laryngeal cancer. Why are we pushing too many patients into radiotherapy? Particularly, I'm interested in this because laser is one of the important tools, whether it is developed or developing countries. The viewpoint is very important. So let's talk about a few things. I mean, I'm just going to initiate some polls and to see whether you can answer this poll. You can answer the poll by just clicking the button, just to make it more interactive. You can press the button. What stage do you think? Is it T1 or T2? I think that's the kind of main question. So that's good. So pretty much people are answering. The results showed it is actually majority of them said T1. Some of them said T2. Some of them said T3. Actually, these all of them are T1 cancer. For example, this is actually diffuse T1 lesion, but slightly bulky. This is very focused, and this is again kind of superficial. All of them are particularly T1 cancer. And this is actually pretty much Still it's a T1, but particularly it's involving the anterior commissure. It's a varying degree. It's very superficial, it's very diffuse, and this is actually bilateral lesion. This is actually anterior commissure, and this is proper anterior commissure. This is actually superficial. There are different types of anterior commissure lesions. So this is actually slightly bigger lesion. It's involving more than one subsite. You can see the anterior commissure a little bit, and this is ventricle, and sometimes it's a cerebral subglottis. So this is clearly immobile cards, bilateral lesion. This is actually T3, particularly on the right-hand side, which is actually a radiorecurrent T3 tumor. This is actually a large lesion, T4. Okay, so let's talk about laser anesthesia. There are different way of giving anesthesia for laser surgery. The whole point is having a good anesthetic team with a clear goals and understanding is crucial for successful laser surgery. You can provide laser surgery with a tubeless field. As you know, laser can cause fire, which is actually a dangerous thing. And so you must provide laser service by giving laser safe endotracheal tubes. And also it can damage your eye. And also it actually damages patient's eye as well. So you have to use appropriate eye protection, depends upon the laser. CO2 laser is a kind of still as a gold standard laser for transoral laser surgery. And for anesthetic, you could use a tubeless field, for example, Hand-Sacker catheters or a tubeless field with some other type of catheters can be used as well. There is options like OptiFlow, which is debatable, but we have successfully used for our transoral laser procedure as well. And we will just go through a few cases and we'll make it more interactive. So this case actually, you can see the patient is undergoing surgery. On the right-hand side, the biopsy proven carcinoma in situ. The left side, modified moderate dysplasia. So this case actually treated by, you could offer a radiotherapy for this patient as well, but we have treated with carbon dioxide laser. Use actually accublate a setting, which is actually it's a straight line, probably 2 millimeter length. I prefer that because it provides a scarless surgery without charring. Because the accublate setting, designed the laser runs between the straight line. So if it is acute spot, you may have to kind of move it to avoid damages to the deeper structure. You can also rotate the angle. That makes it like a kind of vertical cut, and that gives you a better ergodynamic angle to do the operation as well. So it does take 10 to 15 minutes, day case procedure. And this case, we used laser safe laryngeal tube and no damage, no scarring. This is actually type 1 cordectomy, but sometimes on that side, type 2 cordectomy. So it does give a best voice outcome. European classification, it is a basic and also easy classification. Type 1 cordectomy involving epithelium. Type 2 is a little bit deeper in the Laryngeal space. Type 3, part of the ocalis muscle. Type 4, probably full ocalis muscle. Type 5, if you extend to the anterior commissure or subglottis or arytenoid, it's called type 5 cordectomy. This is example of type 1 cordectomy. You're taking the superficial lesion and you can see how it heals up in 6 weeks or 8 weeks time. It heals up like with a normal tissue. because that's why the techniques and also the laser machines are very important. If you do gentle scarless surgery, the vocal cord heals beautifully. This is type 2 cordectomy. You can start seeing the muscle, but I haven't taken the muscle off. This is type 2 cordectomy. This is actually type 3 cordectomy. You can see that. Even though I say type 3, but actually I started here as a type 1, then progressed to type 2, then it gone into type 3 here. So you can't just say I've done type 3 throughout. So it's a kind of cutting as a shallow. And it's actually, even though it looks bad on the anterior commissure, you can see how it heals up. If you preserve the mucosa on either side, it heals beautifully. And I can bet that even after radiotherapy, because nobody looks at these things after radiotherapy as a surgeon. So you don't really see how they're kind of post-operative, post-radiotherapy laryngology pictures. This is case 2. The treatment options are, again, transoral laser surgery or radiotherapy. I feel, but most of the people actually would prefer radiotherapy. Maybe we'll ask what the others' opinion. How do you treat that case? People are voting. Sorry. Sorry, I lost my. And share the results. Actually, most of them said transoral laser surgery, and some of them said radiotherapy as well. Yes, that's good. I'll stop sharing. Okay, that's good. So what did I do? This case, I did a transoral laser surgery. You can see clearly, starting with the type 1, type 2, here type 3, went all the way up to the anterior commissure. And that's how it healed up after 6 weeks. But to be honest, even after radiotherapy, probably you'll get the similar results as well.
From my voice box, and I'm able to talk all right, and no problems at all with it. Very happy with it, in fact.
So transoral laser surgery, especially for early glottic cancer, it can provide a good oncological outcomes. The anterior commissure is always a debatable area. I probably disagree with the general consensus about the anterior commissure. I always feel the anterior commissure is actually a bigger area. It's a larger area. It has got a 5 to kind of 8 millimeter. Are we talking about full entire length of the anterior commissure or entire depth of the anterior commissure? That lot matters. Just some blind blanket things, anterior commissure involvement, I personally don't agree with that. And this one is case 3. It's a bulky T1 lesion. You can see I did transoral laser surgery. I'm just describing the technique. It's this sort of cases, CO2 laser can give you better outcome. You can see this lesion involving the superior, medial, and inferior surface as well. And the palpation of the lesion is very important. That gives you a good feel how much you have to resect. While doing these operations under microscopes, you can actually clearly see the tumor areas and non-tumor areas. Or sometimes, even when you cut with the laser, if that cuts through like a kind of butter without charring, that itself tells you you're not in the tumor area. If you're cutting through the tumor, that charts because of the CO2 interactions with the tumor. So it actually gives you, you can see that after removal of the lesion, we've done the 6 weeks post-op look, but I don't routinely do the 6 weeks post-op look for most of the cases. But if I think this tumor is a little bit tricky or large, then I will try and do the 6 weeks post-op look.
I feel fine, yes.
Is your voice?
It's still a wee bit gruff, but
it's fine.
It's fine, yes.
Okay.
Yes.
Your swallowing is all right?
Yes.
Okay. So this is another case 4. We were discussing the front first. This is actually type 2/type.
I've been here for my operation in July, I think it was the 20th, and I had the laser op done and the lump removed, and then back in again for the second look just to see what's there, and then later on about another 6 weeks I think I'm back in again for another look, and I think that's it. Yeah, we're fine. Yeah.
At the end of the procedure, but actually when you look back, look after 6 weeks or 8 weeks, it does heal beautifully. In fact, especially for elderly patients, it just tends the cord, and actually it is a treatment for first biophonia, to be honest. Their voice actually become more stronger. This is actually a tricky case. It's a diffuse dysplasia, and that's where we have some guidelines. And still, even these cases could be treated with transverse laser surgery and risk reduction. But radiotherapy is actually tricky if it is for severe dysplasia. Or carcinoma in situ is okay, but mild and moderate dysplasia, risk reduction is a key treatment. After laser surgery, we use a cucumber specimen. It actually helps to find the margins. For example, if the tumors are involving this area, then you can go back and remove that part. That actually helps to preserve the vocal cord and the function as well. So understanding the margins about the laser, I don't believe the margins. And also there was a nice talk in the back of laser surgery margins doesn't matter because the laser surgery principles are different. This is the cutting point of the laser, you can see it creates a V-shaped defect because the laser coagulates. So the margins, even if it is positive, still we are talking about 2 to 3 millimeter, you're away, those tissues are charred. So second look is most preferable, or patient side biopsy is more kind of reliable. So this is actually multiple spots. You could argue that this patient could be treated with radiotherapy. Actually, yes, that's one of the options, but actually this is treated by transverse laser surgery with type 1 cordectomy. You can see, just use your butter knife and slice it and it heals up. And this is the second look. You got something in the scarring that was actually a granulation tissue, and then we excised it. That's where we are getting more and more difficult cases. This is actually NBI, sometimes useful for this type of cases. You can see the corkscrew appearance. And this lesion actually starting from here and going all the way and going along the medial part of the vocal cord on the right-hand side. And there is something on the left-hand side as well. So this case, actually, I did do laser surgery. Then we did it in the 2 stages on one side, and then I went back and removed that one on the other side. Again, you can see that that's the first operation, then come back. This is for the second operation, and we have taken some biopsy from the scar tissue. It does produce webbing sometimes. Yes, actually, there was a lesion 2 years down the lane underneath the webbing. That's a difficult thing to correct it. Then that lesion was excised.
So this is my 4th operation to deal with precancerous growth in my voice box. I've decided against radiotherapy. I prefer to have the potential laser treatment, and my voice has plateaued over the last 6 months. Hasn't gotten any worse. It probably hasn't improved any either. So that's where I am just now. So this is my fourth.
So after that, actually, I have excised that and divided the scar tissue with a cold steel. And then after that, his voice is a lot better, but I haven't got his post-op voice. This is case 8. Probably how to ask some polling for this particular case. What do they think about treating this patient? Shall we give radiotherapy or laser, or should we do laryngectomy for this patient? It's staged as actually T2. So interesting. So people are still voting. Right, okay, I'll we'll share the results. You can see the results. Majority voted for radiotherapy. Some of them voted for laser. Actually, a few of them voted for laryngectomy. That's too much, definitely. This case actually, it's almost kind of a little bit deeply infiltrating in the entire cord, anterior commissure. You can see the dynamic view, but there's no subglottic involvement. This is actually treated by transfer laser surgery. This is actually a close-up view. If you look at this very carefully, and I have preserved the mucosa here, and I have partly cut the ocalis muscle here. Still, there are muscles left underneath. Again, same here. And even I went back to the other side of the card. And this is what I talk about anterior commissure. It is a large area. It is not a small area, and it is a 3-dimensional area. Unless you understand this principle, you always kind of hesitant to work in the anterior commissure area. I always explain or tell everyone, you have to use your otological principle while doing laryngeal surgery. You need to have 3-dimensional knowledge. So it does look bad, isn't it? This is what actually 8 weeks post-op for this patient. You can, that's a pre-op picture, how it heals up. It does heal up beautifully. That's exactly.
Just been in for a scope to check my voice. 12 months after the last one, voice is going really well. I work in the gas industry, also a football coach. Voice has improved greatly with that, and I enjoy coaching again.
So that's the best voice you can give, and I can compare that with radiotherapy as well. In fact, I can doubt that radiotherapy can do that kind of voice in that area. So this is another case, what we have discussed earlier. I'm just showing all the cases. This is anterior commissure lesion growth. Someone kind of biopsied it and first sent it to me. And I did this after. Sometimes you get kind of more confidence. You started doing cutting the corners, like instead of doing 2-stage procedure, I started doing 1-stage procedure. Why should I bring this 92-year-old man twice? So yes, it causes stenosis. You can see the length of the anterior commissure become longer.
Transmission unit. The materials that I got for the clutches were faulty, and I had to repair the whole thing myself out of reusable material which was lying in my workshop.
Wow, that's nice.
So there you go, you see.
Are you happy with your voice now?
Yes, I'm happy enough with it. I've lived a long, long time, and I've shouted a lot in my day. But maybe time that I didn't shout so much, perhaps.
Okay.
What about that then?
Great, brilliant. That's why I don't trust this the webs. Are we treating the photos? Or are we kind of actually looking for the voice quality and the other cancer removal? But if you worry about the web, it is actually, but actually it doesn't really affect the patient by outcome measures. this is another proper anterior commissure case. I'm sure half of the people would want to give radiotherapy, but again, I offered both, but patients actually preferred a laser surgery. And this is actually, again, in one go, I started resecting both with anterior commissure on both sides. And actually,
I have been diagnosed with cancer in the voice box. Today, I had my first laser operation to remove one side and the middle part. To me, it's been very, very successful, although I shall return in 6 weeks' time to do the second part. I feel good. I feel my voice is returning already, and I'm glad I have done this.
But having said that, I don't advise actually voice rest. In fact, I encourage them to speak immediately after the operation. I have a feeling there is a myth involvement in like a voice rest for 48 hours or 2 weeks. I just encourage them to drink plenty of water and normal speech. Sometimes I give anti-reflex medications as well. And he's...
Afternoon, hello. I am back here again at Nine Wells Hospital, looking forward to my second part of my laser treatment.
So that's what has happened. We resected it. That's actually, then there is some kind of tissue there, and I re-resected it. It went on like that for 3 years. Then there was something going on again. Then I did resect. I thought of sending him for a radiotherapy, but actually we resected with the laser as well, and that looks really bad, isn't it? So then he went back again. Then actually that was actually granulation tissue. So what is the research evidence for a T1B cancer? The T1B cancer, there's not much evidence, only the Canadian study, which clearly shows actually T1B cancer, that is anterior commissure involvement, it gives a better voice outcome. With the laser surgery can give a better voice outcome and also good curative things. And this is a recent systematic review and meta-analysis of the T1 glottic cancer outcomes, which clearly shows TLM is superior modality in terms of overall survival, disease-specific survival, and laryngeal preservation. It contains 1,200 patients. That's one of the best evidence. So even the ENT UK recent guidelines for a T1 cancer, there's a push towards offering transferal laser surgery, not offering radiotherapy. And because based on this cost. So let's ask the poll people which one they think, which one is expensive, which one is cost effective. You could answer the poll. So who thinks laser surgery is cost effective? That's brilliant. Okay, I think I'm glad I got the right answer. Laser is certainly cost effective, and 95% people said it is cost effective. So it's clearly, it's a 623 from UK standard, and so radiotherapy is nearly 2,600 pounds. So it's almost all the cases can be treated with a laser, whether it is a bulky lesion or it is a non-bulky lesion. You could argue this is a bulky lesion. The bulk is because due to exfoliative growth, but the vocal cord is still there. So it doesn't mean you're kind of removing too much. And this case was actually removed by laser. Once you remove that, still you see the vocalis muscle underneath. So it is not actually a bulky lesion. When you're, that is the point. See, you can see underneath, and there is a nice cleavage between the tumor space. Okay, so this is the case I think we discussed in the morning about management of salvage cancers like T1 or T3 in the recurrence. This is actually a 92-year-old lady who had a T1 tumor treated by radiotherapy, then came back 2 years down the lane. It's actually T3 tumor. This is 92, wheelchair bound, and the options are, I think it's not showing up for some reason, but that's okay. So that case actually, it's a shame it's not showing up for some reason. It was actually treated by transoral laser surgery, which is a type 5 cordectomy. The other option is total laryngectomy, but still that doesn't suit in terms of rehabilitation for a 92-year-old wheelchair bound. Yeah. Okay, so we're coming to the end of the talk. For a transoral laser surgery, you need to have a good team, particularly good anesthetic team, laser safety officer, and you have to develop unique skills. For that, you probably need to go for some training and some cadaveric courses and the laser safety courses. And those are the important basic things to do the laser surgery. So we do run a laser course in Dundee. I think probably this year, certainly we will do that one. I think I come to the end of the talk. Any questions? I'm happy to answer. Good. I think I've caught up some time, so good. There's one question is from Maya. Do you think there's a room for further laser technique advancement to deal with more complex cases in your future? Yes, that is certainly it is possible, even for T2 and to some extent T3 cancers. In some countries, they do treat with a T3, and I would strongly advocate. But in UK, is T3 cancers are still treated with radiotherapy mainly, but there is a role for these cases, especially for a salvage cancer setup. I certainly agree with that. T3 cancers, the voice quality is not as good as the radiotherapy, but you have to think about the laryngeal preservation as well. Brilliant. Okay. Thank you. That's great. I think we will move on to Jenny's talk. Jenny, do you want to share your screen? Brilliant.
Hi, I hope that's okay and you can see my screen.
Absolutely fine. And the next speaker is Dr. Jenny Montgomery. She's one of the dynamic ENT head and neck surgeon who actively promotes outpatient interventional work, which is actually very important in this part of pandemic when there is active reduction in the operating theaters because of increased proven mortality and morbidity due to the COVID and also acquired nosocomial infections. Thank you very much, Jenny, for your time and effort.
Oh, thanks, Jay. Thanks for asking me to talk, and it's lovely to be able to speak to you all about outpatient biopsy in head and neck cancer. So I know we're getting towards the end of the day, and I'll try and keep this as brief as we can. So this will be the outline of the presentation. We'll start with the rationale for outpatient biopsy. We can discuss intraoral biopsies because we really need to start somewhere with this. Then we move on to outpatient endoscopic biopsies, how we can improve our hit rate with those. Then we can look at cancer pathways. I'm very keen on trying to improve cancer pathways, and we can look at the impact upon waiting times. And then we can look at any sort of future or next steps. So if we look at the guidelines available for taking an outpatient biopsy for head and neck cancer, as opposed to doing a general anaesthetic panendoscopy, there are two sort of main documents in circulation, and those are the ENT UK guidelines in 2016 and the BANO standards document, which was produced just last year. And neither of these documents are particularly didactic in saying that you must have a general anaesthetic panendoscopy to diagnose your head and neck cancer. And then in the UK guidelines from 2016, it really just suggests that panendoscopy is only for symptomatic patients or those with a significant risk of a second primary tumour. And the BANO standards document suggests that there should be the facility for all patients to undergo EUA. And there's many cancers that are traditionally biopsied in outpatients. For example, oral cancer is mainly biopsied by local anaesthetic biopsies, but we're interested in other biopsies. We're interested in looking at tonsil biopsies, tongue-based biopsies, supraglottic, glottic and hypopharyngeal biopsies, these ones that traditionally were associated with panendoscopy. So the next document to mention is quite an important document, the Scottish Health Technology Group. And this was published in 2018, and it asked the important clinical question: what is the clinical and cost effectiveness of outpatient biopsy for diagnosis of suspicious lesions of the larynx, pharynx and tongue base? And at the time, the Scottish Health Technology Group did a very robust evidence review looking into this, and they also did a type of cost analysis called a budget impact analysis, and that suggested that this was a very safe, good way to diagnose patients, and it could also be cost effective. So I suppose at this point in time, I'd like to give a disclaimer that I'm not completely opposed to panendoscopy, and in fact, I'll do this several times, and there's certain areas that I think a panendoscopy is always going to be necessary and is a very important diagnostic tool. And although this isn't the best picture, it's quite a bulky laryngeal surface of epiglottis picture, that area is very difficult to get to with flexible biopsy forceps. And this is a true glottic lesion. But again, I quite like to have a look at these under general anaesthetic because it's good to be able to truly assess those before you attempt laser resection, as Jay's already covered. So when you begin taking outpatient biopsies, I think a good place to start is the tonsil. You don't need any endoscopic special biopsy kit to do this. You can just get them to open their mouth and have a pair of forceps. So this is the easiest way to start to biopsy patients in the outpatient clinic. How I do this and how we do this at our clinic is we use chlorphenocaine spray and then use a dental needle and syringe to infiltrate the area once it's been sprayed up. And it really helps to have a good pair of oral biopsy forceps. And these pictures show a disposable pair of oral biopsy forceps that we have at our clinic, and they're made by Chef Med, and the outpatient staff can just order them, and they take good little biopsies from the tonsils, and we've got a very good hit rate with those. Endoscopic biopsy is probably the next step in this pathway, and you can see our stack that we use in clinic. And it's really an excellent stack. And if you can see my arrow, this is the stack, and you can see the tiny little light box that we had before. So the stack for us has been a massive step up in how we can both visualize and biopsy patients and outpatients. And obviously in the post-COVID world, you've got to do all this with your PPE on, but it's still entirely possible to do this. And I do think there's a difficulty gradient when you're taking outpatient biopsies. So I think it's easiest to start with the tonsil and then move on to the tongue base, because we're starting to bring in endoscopic equipment for this, supraglottis, and then getting into the true glottis and the hypopharynx can sometimes be a little bit trickier using the scope. And one of the main things that I really have to highlight is getting patients comfortable before you begin. And I use normally chlorphenolquine spray into a patient's nose before we begin, and sometimes into their mouth as well. But after doing that, I would use 4% lignocaine. And this is the same strength of anaesthetic that's used by anaesthetists when they're doing a weak fibre optic intubation. And you can also see this atomization device. Again, it's quite cheap and easy to order at outpatients. But the good thing about this is it's entirely malleable. So you can draw up the local anaesthetic in the syringe, and you can bend that into to either their tongue base area or their glottis, and really get the local anaesthetic over that area. And it helps just to do that before you start to scope them and the patient's already very comfortable. And you might wonder, well, the endoscopic channel of the laryngoscope has a channel that you can squirt anaesthetic down, but I actually prefer to use this beforehand, because when you squirt anaesthetic down and then you put your biopsy forceps through, you sometimes just continue to push little bubbles of fluid out of the scope, and that can just impair your view a little bit. So I try to get them as comfortable as they can before they begin. Just to go back to another set of biopsies that I think are really easy to do without using any fancy equipment. You can biopsy nasopharynx tumours very, very easily at outpatients, and you can borrow some laryngeal biopsy forceps from theatre. You don't need anything endoscopic for that. You can use a rigid nasendoscope and just use a pair of long forceps. Or if you're very keen, you can use the endoscopic biopsy channel endoscope to pass the flexible wire biopsies along, but it's very easy to do that without any extra special sort of fancy kit. So if we want to do an endoscopic biopsy, really the main thing I have to hammer home is you must ensure that the patient's really comfortable, and it's good just to do that before you begin. Another thing is at clinic, you need 2 people to do an endoscopic biopsy. So one person to navigate the scope and the other person to feed down the flexible forceps. And before your assistant begins, I usually, depending on who it is, get the person to open and close the forceps a few times and just make sure that they are happy opening and closing them. I usually inform the patient that we need 4 to 5 samples. Because sometimes you can just catch a superficial part of the tumour, but you really need to get into it quite deeply to ensure that you get a malignant diagnosis from it. And I tend to try and biopsy the same area repeatedly as well. So if you take off the surface of a lesion, just keep biopsying down the same hole as much as you can, because then you'll really get hopefully a diagnosis from that sample, and you won't need to arrange any repeat biopsying. When you take out the wire forceps from the endoscope, it's really helpful to have a needle nearby to get the sample out of the forceps, because as you know, it's really only a 2 millimeter biopsy forceps that we can fit down the endoscope. So you really want to be able to have a needle to scrape the sample out of the biopsy forceps. And very importantly as well, have a bowl and a drink of water for your patient, because they're going to want to spit out afterwards and they need to do some gargling and things like that. So I hope this video will work. So this is one that took at clinic yesterday, and you can just see down here that there's a tumour in the tongue base here, and it's got this sort of central kind of, if I ever hold the camera still, sorry, there's a sort of central of necrotic area. Now, I don't really want to biopsy that, because that's just necrotic slough, and I don't think that will get me a diagnosis. So then we get the biopsy forceps coming in, and I'm still looking about for something at the edge of the tumour that I can get that will hopefully give me a diagnosis. And this area here looks like more viable tumour than the sort of central necrotic area. And I just keep the forceps close to the endoscope so that I can really drive that into the tumour. And for areas in the tongue base, I try to drive the endoscope into the tumour. And I think that's the best and easiest way to get a good sample. For areas on the glottis or the epiglottis and the undersurface, I sometimes will advance the biopsy forceps further because you can't really drive the whole endoscope into that lesion because you'll make the patient cough a lot and maybe even be sick. So that's really best avoided. So, but if you can, just try and put the endoscope into the tumour as much as you can so that you get a nice deep sample from it. So moving on, do patients tolerate outpatient biopsy? Well, our experience in Glasgow certainly is that yes, they do. They tolerate it very, very well. And if you look at the literature, the abandonment rate of the procedure is less than 1%. If we consider safety, the complication rate is also less than 1%, and this is in 19 published studies. And if we look at complications, most of them are quite self-limiting in the outpatient clinic. Diagnostic hit rate is very important, and sensitivity of taking outpatient biopsies is reported between 64 and 97%, and specificity between 87 and 100%. And you might wonder, what do you do if your biopsy just, for example, shows carcinoma in situ? Well, it depends really how sort of comfortable you are as the next step. And sometimes I know that if we can take a deeper biopsy, I will just go for that again in outpatients. But in other patients, I will bring them in for a GA if I'm worried that it's very deep or submucosal. But I'd also like to point out that just because you're doing a general anaesthetic biopsy of a patient, it doesn't ensure that you will get a cancerous diagnosis the first time. And in fact, one patient that springs to mind quite recently had a tongue-based tumour that was mainly submucosal, and I got carcinoma in situ from the endoscopic biopsy. I brought them into theatre, took biopsies and removed 2 cubic centimetres of tongue base, and there was no cancer in that. And it was only on the second panendoscopy. So these patients that have tumours that are difficult to biopsy generally tend to be difficult to diagnose anyway, I find. So can we look at the effects on the cancer pathway? Well, if we look at the literature, there are 4 studies published that focus on this. And this is all quite recent in the past few years. But the days saved on the cancer pathway are very interesting. So really, in the reported literature, the days saved are between 2 to 24 days, with a mean of almost really 2 weeks. And that's a very good reduction in sort of cancer pathway time. We've looked at this just with our experience, and since we've had our stacks, which we got in around July 2019, and since then we've put through about 500 odd patients with head and neck cancer, and in the pathway we have 244 that went through a local anaesthetic pathway, and 287 that went through a general anaesthetic pathway. And if we look at these figures, well, one thing that I'd like to point out from a cancer pathway time is that we don't meet the 14-day criteria for seeing our patients quickly enough. And this is something that we're working very hard to improve, but it's very difficult with the sort of resources that we have and the amount of referrals that we receive. But this is something that we really need to work on. If we look at the mean days from clinic to biopsy, if we consider the local anaesthetic biopsy pathway, we're looking at 12.5 days for a biopsy. But for general anaesthetic, we're looking at 26 days. So when we come to consider our mean days from the USOC or urgent suspicion of cancer referral to the treatment decision, which in cancer pathway times is the 31-day target, which is laid out by the Scottish Government. So that's the time from which the GP refers the patient for you being able to make a treatment decision. In the local anaesthetic pathway, we're looking at almost 50 days for that, which again is still not very good. That should be 31 days or less. But the general anaesthetic pathway is 68 days, and that's a significant difference. But we're saving about 18 days from the pathway by biopsying them in outpatients. So if we consider safety, that's very important. There are 19 published studies that report on safety, and 14 studies don't report any complications. The ones that do report on complications look at things like vasovagal reactions, epistaxis, vocal cord hematoma, one more serious case of laryngeal edema, which led to a tracheostomy the next day in a patient that had a large transglottic carcinoma. And I think that obviously that is a concern, but you need to pick your case selection quite carefully. And in a patient with a transglottic carcinoma, you know, if there's bleeding into that airway, or that an airway is lost, then you would think if it was a real emergency, they would have to go to theatre that same day. So it may just be that, you know, that was quite a big tumour to be biopsying in outpatients. But it's interesting that author Wellenstein, in the same paper published, that state that anticoagulation is not a contraindication to local anaesthetic biopsy. Now, that's probably a slightly more complicated area, and certainly in our clinic we're a bit more cautious about anticoagulated patients. So if they're on aspirin or clopidogrel, we'll carry on and biopsy them. But if they're, for example, if they're on warfarinized or the DOAC agents, we would normally, especially if it was in the airway, we might stop or reduce the warfarin until their INR comes down a little bit. But the DOAC agents, we would normally withdraw them for a few days before taking biopsies. And it's interesting that these safety studies don't report any comparison with general anaesthetic panendoscopy. And I think that's quite an important omission, because if you look at general anaesthetic panendoscopy, there's not one of us that would say that procedure's without complication. And we can look at things like dental trauma, bleeding, conversion of marginal airways to tracheostomies, you know, perforation. There are serious complications that can result from general anaesthetic or panendoscopy, but they don't tend to be reported in the same sort of category. So that's something that needs to be looked into. So to round up, and you might be pleased we're getting towards the end of this, but the future, I think we really need to look at more studies on patient experience. This area is kind of sadly lacking. There's 1 or 2 studies that actually report that patients tolerate it very well. And anecdotally, that would be my opinion as well, that patients do tolerate it well, as long as you get those patients comfortable before you begin. I think the question we need to ask ourselves really for the future is that should outpatient biopsy be the first line diagnostic strategy wherever possible? Because when you look at the literature and look at our experience, I think we can safely say it's a safe process, and we can say that it can effectively shorten the cancer pathway. So those are my take-home messages, and that's all I would really like to say. So thank you very much for listening, and I'll take any questions.
That's a great lecture, Jenny. I totally agree with you. I think that the way forward is both outpatient intervention. It's not only because of the pandemic, but it is clearly shows it's cost effective, it's fast, and it speeds up the treatment process. It's well tolerated procedure. And one more thing I want to just point out, I know when your slide showed the sensitivity is 64 to 90%. I read the 19 studies because Jenny and myself involved in the systematic review. It's just about to be kind of submitted as well, the one gone for review. And the earlier scopes studies, which was published in Korea and America, they were using old fiber endoscopes. The old fiber endoscopes has got some disadvantages, but the newer ones actually called the chip in the tip, and that has got a 4K quality, HD quality, and actually it dramatically increases the sensitivity and specificity. Especially the working channel from the endoscopes are much superior. and the biopsy forceps are also good. So the recent studies actually quoting the sensitivity and specificity is much, much higher. In fact, they're very close to 95%. If you exclude the earlier studies, which was published 10 years ago, actually it's a 10 years old technique, but we are popularizing it now. I think there is a question from our trainee, Rashad. Jenny, can you able to see the question, or do you want?
I'm just trying to see how I can see that.
In Q&A.
Q&A, sorry about that.
That's okay, I can read it.
Anesthetics are done pre-imaging. Yeah, so you're quite right, Rashad, that yes, they are done pre-imaging. But what you can, I don't have any major concerns about upstaging a tumour on imaging, and that's certainly not anything that's been reported in the literature. As Jay says, we've done very extensive reviews into the literature lately. But the biopsies that we're generally taking are a lot smaller. So we're not creating any new big cavities in a tumour that it could potentially create a lot of surrounding edema. And that is that's one of the good things about it, is it's a relatively atraumatic procedure compared to big chunky biopsy forceps. And that has a knock-on effect for pathology. And I had to discuss this with our pathologists when we started doing this. Were they happy with the biopsies? Were they able to process them? And they are, because this is the size of biopsies they get from other specialties like urology and upper GI. So there's not really been any problem with us sort of from a pathological effect or from upstaging on imaging. But thanks, good question. And then there's a question about xylocaine spray. And yes, you're right. So I think, although that says exclamation 0, you can use 10% spray as well. We use 4%. That's just what we use in our hospital, and it works very, very well. But yes, you can use 10%. Xylocaine lozenges, yep, you could also use that. We looked into that with our pharmacy, and I think basically what they came down to was what was cheaper, and the 4% seems to be the most cost-effective thing for us. Michael Hopkins asks, do you bring suitable patients back to a specialist biopsy clinic, or can you do them at the initial clinic appointment? Well, yeah, you can see that because our median day to biopsy is, for local anaesthetic biopsies, is 12 days. So if the patient comes to our diagnostic clinic, we can biopsy them same day. But a lot of our patients with cancer will come from our colleagues that refer them to us for outpatient biopsy. So you can bring them back. But usually that's just another patient that's referred in, but usually we'll biopsy these on the same day. So specially angulated biopsy forceps, there are not at present, but actually we're working with a company to make a slightly angled one that I find is quite good for biopsying tongue-based lesions. And it's just like a slightly longer, more angled version of the oral biopsy forceps. And the difference is that the biopsy forceps actually side opening, because what you want to do is open the jaws of the forceps and push that down on top of the tumor to biopsy these sort of like close to the sort of anterior tongue-based tumors. And the reason that I'm doing that is purely just for speed. So I can take 1 or 2 little samples from those patients and they're way out the door. But if I'm using my endoscope, I want to take 4 or 5. So it's just purely to make that that easier. KH asked, do we attempt transnasal esophagoscopy? No. You can see that we are struggling to maintain any sort of cancer pathway targets, and we don't do esophagoscopy routinely in these patients because one, when you're assessing head and neck cancer, we only really need to assess their esophagus if we're suspecting a second primary. And imaging is good enough such now that we can rely on imaging to upstage a tumour or highlight us to a second primary. So we're not routinely screening the esophagus in these patients. And that's a step away from older practice, but that's I think more modern practice. I think that might be all the questions.
Yep, that's brilliant. So a lot of questions I think we have answered since morning, so more than 48 questions. That's great. I think it's become very interactive. I think Stuart, sorry, Mr. Murray, Dr. Murray wants to say something.
Yeah, so I was just going to support Jenny and say that she had touched on anticoagulation and antiplatelet treatment. I suppose we've got 5 years worth of data for outpatient biopsy in one of our peripheral hospitals. So it'll be 400 patients, and allowing patients to stop a DOAC the day before, or accepting patients on warfarin with an INR of up to 2.5, which would cover pretty much all atrial fibrillation or PE related indications for anticoagulation, that we've had no complications from that. So I would think that the future would be reasonably rosy for adapting the pathway slightly to be able to accommodate patients with anticoagulation.
Yeah, and I think that's a very good point, Murray. So there's a document produced by the sort of national dental surgeons that look at anticoagulation and dental extraction, and they recommend that you can continue sort of performing dental extractions in patients that are actively warfarinized up to 3. So I think if you can take out a tooth, you can take a small sample from their tongue. So yeah, thank you. Good point.
Brilliant. Thank you very much. I think we come to the last part, but not the least one. Shiying is one of our trainee who is going to make it more interactive, but she's going to touch base some basic anatomical kind of questions, as well as treatment questions, just to answer some of the exam-based, but it is not a true representation, but it is just stimulating your knowledge and enhancing your lateral thinking. That's what I would put it. Okay. And this one